Good afternoon to everyone. So we will continue our discussion on the nursing pharmacology, specifically in the introduction of the pharmacology. So as we start again our discussion for this afternoon with the prayer of our Centralino RN prayer. Our Almighty Creator, we praise and glorify your name. We humbly submit ourselves on your vital intention to claim the Centralino RN. Help us attain the optimum health at all times with perseverance and leading to our RN goals. Nurture us with your spirit to keep our open mind to absorb and retain the lectures and skills concepts according to the nurse licensure examination framework. Let us decide to complete every examinations according to your will with prudence and integrity. We appreciate you on our existence to contribute in Centralino 100% through teamwork. As we leave ourselves to you on our journey with the core objectives of the MCU College of Nursing. Amen. Let your spirit be upon those students of N21, have their optimum health, stamina, and hydrate them, Lord, so that they could absorb our lesson for this afternoon. We extend also our prayer for our graduates who will take the nurse licensure examination on November 12 and 13. This we ask in your mighty name. Amen. So, as we start with our discussion, we will have the interactive discussion on the slido.com. Last month, we have celebrated the Patient Safety Month, October. And one of the common concerns that really affect the patient safety is 60% is on the medication error. So here is a survey. You may join at slido.com with the code 222242889. These are the common medication safety issues. So which of the following safety issues will greatly affect the performance of nurses in any healthcare setting? So you may start your response by again proceeding to the slido.com. So you may start so that we could explore on some of the safety issues that will be connected later in our discussion of the rights of medication. So on the rank of the same rank, we have overdosage or underdosage. We have non-reporting of adverse reaction. So we have overload the patient's assignments. Third, we have non-compliance with prescribed medications. So rank number 1 now is overdosage or underdosage. So please continue answering our survey, our interactive session now, because again, when it comes to the perspective of how the nurse will really promote patient safety is to follow the rights of medication, patient safety measures, and standards of care in the administration of drug. So it seems the number one, the rank 1 of the common medication safety issues are on the overdosage or underdosage. Number 2 is non-reporting of adverse reaction. Third is non-compliance with prescribed medications. And fourth, overload of patients. So just continue to answer on our survey. However, as ranked accordingly, the overdosage and underdosage had been considered as a medication safety issues. Probably in this concern, the overdosage merely may lead to the toxicity level, or possibly it may lead to adverse reactions that could take risks or could be life-threatening for the patient. Underdosage could be also a problem because if ever the patient will require a certain number or certain amount or volume of drug that is indicated for his or her condition, it will not attain its desired effect because it's under dosage. So you may ask a question, sir, which of the two is worse? Is it overdosage or underdosage? Actually, both. Because in overdosage, again, the liver will forcefully function to metabolize and prevent specifically the adverse reactions and the toxic effect. However, on the underdosage naman, this will consider the drug that may not cause biochemical change or physiologic change to the body because it did not attain the prescribed dosage to process basically the health condition of our client. So it seems in your number 2, non-reporting of adverse reaction ranked number 2. This is also a medication safety issue to the extent that we all know that adverse reaction have been defined as harmful, okay, harmful reactions of drug to the body. So just similar when you had your vaccination, okay, your vaccine, you have received your vaccine, and if ever you have encountered unusual reactions of vaccine, this must be supposedly reported, okay, to the nearest health center or city health office, because adverse reactions, as what we have mentioned and defined, cause a harmful reaction to the body, thus may lead to toxic effect of the body. So we have a common term that we have discussed before, that the study of adverse reactions are referring to pharmacovigilance. In number 3, it was ranked number 3, the non-compliance of prescribed medications. If we consider the term non-compliance, it also weigh already a problem with the drug administration itself. Why? Because to the extent that this will consider, it's either the prescribed medications that we are talking about is the prescribed dose, the supposedly drug that must be taken by the patient accordingly, or non-compliance is referring to totally the patient did not take the prescribed medication. So this may affect mainly the objective of meeting its therapeutic effect. Number 4, overload of patient assignments is the least among the rank. And it considered po dito na this is referring to the nurse's workload. This may possibly take risk on the situation that if ever the patient ratio is above the standards, meaning there's a certain ratio certain ratio that is supposedly being managed or can be tolerated by a nurse, which is for ambulatory client. It could be 1:7 to at least 10 patients. But if you are handling more than 10, then this could possibly cause a concern when it comes to the monitoring or proper medication protocols in terms of the education, in terms of monitoring of adverse reactions. So those may consider a problem. All of these answers are correct. It so happened that it explore our mind that you have answered number 1 because this is somehow a higher percentage that may really lead a medication safety issue to our patients and even to ourselves. So thank you so much for your responses. Let us continue. The different terms that we have encountered related to the drug movement or absorption is referring to diffusion. Diffusion, it is defined as the transport from higher concentration to lower concentration. That's why when the drug enters the body and reach its peak concentration level, ibig sabihin, the peak itself is higher concentration. And once the liver will metabolize, it will now decrease the concentration. So that is mainly what we are referring to the diffusion. So that's why when drug reaches the plasma, that reach actually the Cmax or the maximum concentration. And since it will be metabolized by the liver and excreted by the kidney, the concentration of the drug will be lowered. So once the drug reaches its peak concentration level or 100%, that is what we call bioavailability. When the drug again reaches 100%, as it reached the plasma or peak concentration level, that's what we call bioavailability. Next, we have also considered pinocytosis as an active transport. Drugs can be distributed or can be transported through the fluids, just like plasma. Plasma is part of the blood, and this is a fluid that carries all nutrients and waste products, including the drug composition or chemical properties of the drug. So other fluids that could be identified in other organs could be intracellular fluid, extracellular fluid, so meaning that is within the cell. Say, there could be synovial fluid that's present in the joint, pericardial fluid that is present in the heart, pleural fluid that is present in the lungs. So these fluids are very significant when it comes to the transport. So that's why it is considered as active transport. Okay, next po. Just a reminder po, if you have any question, you can put it in our chat box, or you may raise your hand so you will be called, or you may unmute yourselves if you will have any clarifications. So let us continue. Actually, the next audiovisual presentation will focus on the continuation on pharmacokinetics. Let us watch.
Hi, in this tutorial I'm going to talk about the distribution of drugs within body compartments. In the previous tutorial I said that this video would be on the metabolism of drugs, but I've decided that it's probably best to talk about the distribution of drugs before we move on to metabolism. For the purposes of distribution, we can consider that the body is made up of 4 major compartments, which are really collections of fluid, and numerous minor compartments. These major compartments are the blood, or strictly speaking the plasma, fat, extracellular fluid, and intracellular fluid. Then there are numerous other minor compartments. These include the cerebrospinal fluid, the peritoneum, synovial fluid in joints, and the fetus in pregnancy. There are numerous others, but for the purposes of...
Okay, so just to give you an overview that what have been said in the audiovisual presentation, if you can still remember the concepts that we have discussed on the pinocytosis, this is now the time that when the drug will be introduced into the body and it is via blood, right? So what are those compartments that had been identified for the distribution of drugs? If the drug had been given directly to the blood or blood vessel, and the blood has the plasma itself can already do that distribution of the drug. However, there are also other mechanisms to distribute the blood plasma with the drug. So that could be in the extracellular fluid and the intracellular fluid. These are 2 compartments of cells, extracellular compartment and intracellular compartment. These compartments has fluids which mentioned as extracellular and intracellular fluids. Extracellular fluid is composed of electrolytes. So we have highest electrolyte, positive electrolyte, or cation is we have sodium. The highest negatively charged electrolyte in the extracellular compartment or fluid is chloride. That's why if you notice, most of the IV fluid preparations has sodium and chloride, because eventually the cell will be dehydrated. It will pass through immediately the sodium and the chloride. Other than that, most of the IV fluids has also sodium and chloride because this will initiate transport of drug properties to extracellular compartment or fluid. The next is that of in the intracellular fluid, we have also electrolytes. The highest electrolytes in the intracellular fluid is potassium, and the negatively charged is phosphate. Let us have a review. Extracellular, we have positively charged, highest is sodium, negatively charged, chloride. For the intracellular, the highest positively charged electrolyte, potassium. Negatively charged electrolyte, phosphate. Sir, why there's a compartment such as fat? Class, there are drugs that are lipid soluble. It means that there are some drugs that may need to process, not just like water soluble drug, it can be easily distributed. So for those lipid soluble drugs, it will be distributed primarily to the fat compartment. Fluids all over the body can be significant when it comes to the transport, as what we had mentioned in the pinocytosis. That's why there are other fluids that are significant in the distribution. We have CSF, or cerebrospinal fluid. We have peritoneal fluid in the peritoneum. This is the peritoneal cavity that covers abdominal organs. Synovial fluid. These are the fluids that are present in the joints. And the fetus is the amniotic fluid. So these are the means on how the drugs will be distributed accordingly. Let us continue on how the drugs will bind and distributed to this compartment efficiently and effectively. Let us continue. And it needs again the video. Let's go back. So we will go back to this area. Let's continue. It's not playing. But for the meantime, let us check the audiovisual presentation. It's not working. So while waiting for the slide or the video to open. So let's wait for it. Okay. So we will just close and open the presentation again. So again, sorry for the inconvenience. Let us start again we will share again the presentation for a while. Okay. So let us proceed. So we'll just await for the no. Again, if you have any question, just don't be hesitant to ask for. Okay, for a while. Okay. Okay, here we go. Let's continue. Let's continue again to share. Something wrong. So just for a while, I'm just managing the technical concerns on my PowerPoint is not working. Okay, so it just overlapped. So just for a while, I'll just manage the presentation. Noted on those notifications. Let's start again. Hmm. Okay, so it seems it's not working. My video presentations are not working. It's again for a while. Okay, let's continue. Hoping this will play. Hmm. Probably let's start. Let us just start it from the top.
Hi, in this tutorial I'm going to talk about the distribution of drugs within body compartments. In the previous tutorial I said that this video would be on the metabolism of drugs, but I've decided that it's probably best to talk about the distribution of drugs before we move on to metabolism. For the purposes of distribution, we can consider that the body is made up of 4 major compartments, which are really collections of fluid, and numerous minor compartments. These major compartments are the blood, or strictly speaking, the plasma, fat, extracellular fluid, and intracellular fluid. Then there are numerous other minor compartments. These include the cerebrospinal fluid, the peritoneum, synovial fluid in joints, and the fetus in pregnancy. There are numerous others, but for the purposes of this tutorial, we'll consider these as one single compartment. So if a drug is placed into one of the compartments, we can see how it might move and distribute into other compartments. Often drugs are placed into the blood. These are drugs which are given intravenously. So when a drug is placed into a compartment, it often associates with binding molecules. These binding molecules are often proteins such as albumin. This process sequesters the drug within the compartment, effectively increasing that compartment's storage capacity. And there is an equilibrium maintained between the bound drug and the unbound drug. The unbound drug within a compartment is then able to move into a new compartment, and thus an equilibrium is maintained between adjacent compartments. When a drug moves into a new compartment, some of that drug is sequestered by binding molecules within that new compartment.
Actually, the binding molecule that is referring to is that of this will aid to distribute the drug chemical properties to the different compartments. And that binding protein that we're referring are albumin. So albumin is the one that is very important component for the distribution of the drug as the binding protein factor. Let's continue.
This process continues until there is a balance between each compartment and a balance between the amount of free drug versus bound drug within each compartment. The balance between each compartment is determined by a number of factors, and this is best represented using an equilibrium constant.
Okay,
Then all
so
you
we'll
need
just
constants
pass
for the
those
one compartment versus pH
discussion.
compartment.
Actually,
The
there are
binding capacity
factors. There are
may or
factors
may
that
not.
will. There are factors that will affect mainly distribution of drugs. It's on the three permeability of barriers. We have the pH of compartments and the binding capacity. If we say permeability of barriers, actually class, if for example, if the blood is high in the alcohol or high in the nicotine, which is the component of smoke, this will affect mainly the permeability of each compartment tissues because somehow it may cause the constriction, it may limit the flow of distribution of drug. Second is, this may depend on the pH of compartments. The pH is related to concentration. If the compartments are too acidic or too alkalinic, the chemical components of the drugs will break down and it will decrease its concentration. And third is, the distribution of the drug is dependent on the binding capacity, which I have mentioned about the protein binding capacity, such as the albumin. If these three are considered po as barriers or reasons that may cause the possibility of affecting distribution, these three are greatly dependent on this situation. So let us continue. As we go on with the distribution, this when the drug enters the body, it enters to the plasma, then that's absorption. And when the drug reaches the blood, plasma, and it will now be distributed to the compartment tissues, then now distribution starts. So usually, ang distribution po are affected by various physiologic factors. We have the BBB, or the blood-brain barrier. If we say blood-brain barrier, it's obviously the brain. And if ever there are some toxins that enters the brain, it will prevent to damage the cerebral tissues, because this is definitely important to prevent the damage to the tissues as well as with the cellular functioning. So yun nga lang, if the blood-brain barrier will be affected, it will limit the distribution to the sa central nervous system, which is basically dependent, di ba, diyan ang circulation of the cerebrospinal fluid. Another concern is pag ang drug nyo po ay lipid soluble, it cannot be breakdown. So it goes slowly kasi mas viscous po ang lipid soluble drug compared to water soluble. So ibig sabihin, kung lipid soluble siya, there is a component that is high dense na hindi siya magpapass through glial cells. And glial cells are present also in the central nervous system. Another factor that may affect distribution is cardiac output. Okay, I may just ask po anyone, you may type it in our chat box. What is the normal cardiac output? If you can still remember the circulatory system in your anatomy and physiology, how many ml or liters every minute that the heart produces as a normal cardiac output? You can now post in our chat box, whoever knows the normal cardiac output, how many liters per minute or how many ml per minute? Can anyone type in the chat box a response? Okay, how many liters or how many ml is the normal cardiac output? With our 28 students in our Zoom now. So, I have seen a response. Yes, so thank you so much. Yan, so we have answers 5 to 6, 4 to 8, 5 to 6 liters. So, the answer is almost also a minimum of 5,000 ml or 5 liters per minute. So if the cardiac output is less than 5 liters per minute, this will affect distribution of the drug. So, alam niyo po that the cardiac output po, 40% of the cardiac output goes to the brain and the rest of the percentage will be distributed to the major organs. So, what are those conditions that will really affect cardiac output? So, those conditions that, for example, as what I have told you, if there's an increase in the alcohol level sa blood, it will cause constriction of the aorta. So yung aorta po is the one that could be the blood vessel gearing towards systemic circulation. So if the aorta will be constricted, then it will not pass through the cardiac output and distribute the drug to its systemic circulation. Another is if we have a concern certainly with the high blood pressure, expect po pagka hypertension or high blood pressure, there is less cardiac output. So this will significantly affect distribution of drug. Next po, letter C, body composition. Most of the obese clients or overweight individuals have large amount of adipose tissues. Kung mataas po ang composition of adipose tissues, expect po na mababa po or mabagal, slow ang metabolic activity. Remember, metabolic or metabolism is very important so that to support distribution of drug. So that's why for those who are overweight or obese, sila po yung kung mabagal ang metabolic activity, slow din po ang distribution of drug. Another is blood supply to target tissue. So similar with cardiac output, if there will be less blood supply to the target tissues, example, stomach. If in the stomach, the person has peptic ulcer, are already experiencing gastric bleeding, then this affect the blood supply and this may affect significantly distribution of blood. Next, the degree of vessel constriction and dilation. So if again blood vessels are constricted, it may impede or it may decrease blood flow. And the degree to which the drug binds to plasma such as albumin. So kung mababa pong albumin, then this will not cause efficient and effective distribution of drug. So the next po is we will have an audiovisual presentation that will focus on metabolism. How the drugs will be metabolized by the body. Let's continue.
Hi, welcome to the fourth handwritten tutorial on pharmacokinetics. In this tutorial, I'm going to talk about drug metabolism. Drug metabolism often takes place in the liver, but metabolism can take place elsewhere, such as in the lungs or the gut. The fact that most drugs get metabolized by the liver is very important for pharmacokinetics, because drugs given orally may be metabolized by the liver before they reach the systemic circulation. This phenomenon is known as first-pass metabolism. Sometimes first-pass metabolism is so dramatic that it necessitates giving a drug intravenously, as giving it orally would lead to significantly less active drug in the systemic circulation. Morphine is an example of this, which is why it is so often given intravenously rather than orally. However, in this tutorial, I'm going to talk more about the biochemistry of drug metabolism, in particular, the actions of cytochrome P450 enzymes, which are often abbreviated CYP. These cytochrome P450 enzymes are abundant in the liver and different types metabolize different drugs. For example, CYP1A2 metabolizes caffeine, whereas CYP2E1 metabolizes alcohol. Cytochrome P450 enzymes metabolize drugs through a variety of processes. These include oxidation, hydrolysis, and hydroxylation. So let's have a look at how this works.
Okay, so just to keep it simple, do you know that class, the liver has a major function when it comes to detoxification. If there's an increase in the level of alcohol in the blood, there's a cytochrome, separate cytochrome that will prevent the excess level of alcohol in the blood. Similar also with increase in the fats. Liver is the one that metabolizes fats. So there is a separate cytochrome enzymes. For the nicotine that is that are coming from the cigarette smoke, then I think we have a separate cytochrome also that's responsible for that. So can you imagine the cytochrome enzymes that are being produced by the liver so that to facilitate eventually uh, detoxification? So for the drug, we have the cytochrome P450. This is the enzyme that facilitates the metabolism of the drug. And with the process that had been considered, the oxidation, hydrolysis, and the hydroxylation, this entails on how the drug will undergo the process, the chemical process, so that it will prevent the level or increased level of drug that will cause toxic effect in the body. In the process, it will continue to have the chemical metabolism until it will be excreted to the kidneys or via kidneys. So this is just the most important concept of the metabolism based from this audiovisual presentation. That's why when we talk about metabolism, there are many means to consider po that metabolism could be alteration of a drug from its dosage form to water soluble form. So that's why, as what I've mentioned, yung lipid soluble could be distributed slowly, could be metabolized slowly compared to water soluble form. And most of the drugs can be metabolized via the liver, the plasma, the kidneys, or the intestinal membranes. So that's why there are, for example, if you're taking multivitamins, the metabolism in the liver, okay, follow through the kidneys, and excess composition or chemical properties of the drug are being excreted by the kidneys. If you take iron-based drug are metabolized by the liver. And by the liver, it passes through the hepatobiliary tract, and that's why it may appear the excess or excrete the excess level of iron via the stool. So that's why it may cause discoloration of the stool. Usually, metabolism may be affected by genetics. Genetics meaning those inherited disorders that will significantly affect those that I have mentioned that is also similar with physiologic factors for distribution. Patient's age and physical condition. The elders are the ones who could be vulnerable when it comes to adverse reactions. That's why if we will try to consider your principle that in the increasing age the metabolism is low, so eventually the detoxification or the metabolism of drug is also slow. Okay, that's why most of the elders are high risk for adverse reactions, toxic effects, hypersensitivity reactions, because the body of an elder has a slow response against these concerns with drug reactions. The drug itself. So the first pass effect, not all drugs that are being administered to the body will pass through the first pass effect or first pass metabolism. Most common drugs are usually influenced by oral medications, those that are being taken per orem. So once it reaches the stomach, it reaches the intestinal tract, and as it reaches plasma class, it will primarily metabolized by the liver as first pass effect. If the drug will be administered through intravenous, it may not pass through first pass effect. So that's why most of the first pass effect are usually considered po for the oral medication or administered through oral. So next is the excretion. How excretion happens when it comes to drug as decreases its concentration after the peak concentration level. Let us continue watching an audiovisual presentation.
Hi, this tutorial is the fifth in the Pharmacokinetics series. In this video, we'll be discussing excretion of drugs. Excretion is defined as the irreversible removal of drugs from the body. There are two main ways in which the body excretes drugs. One is via the hepatobiliary system. This is when the liver excretes a drug or a drug metabolite into the bile, which in turn gets excreted with the feces. An example of a drug which is primarily excreted by the hepatobiliary system is the antibiotic rifampicin. However, most drugs are primarily excreted by the kidneys. As such, we will focus on this system in this tutorial. In this system of excretion, a drug gets filtered into the nephron of the kidney. If you want more information on the details of this, check out the nephron function tutorial and other kidney tutorials at handwrittentutorials.com. Once the drug is in the nephron, it flows through the nephron into the collecting ducts and ultimately out of the body in the urine. So we can define some values here. First of all, there is a certain concentration of the drug in the plasma. We'll denote this Cp. Secondly, there will be a certain concentration of drug in the urine. We'll denote this Cu. Finally, there will be a certain rate at which urine is being produced.
Okay, just to give you a simplified discussion on this, when the drug had been metabolized by the liver, it will excess composition of the drug will be managed by the nephron. The nephron is the basic unit of the kidneys. It will pass through the different tubules, and these tubules will manage the what we call clearance. The kidney is the one that clears drug. Kaya that's why po, class, when a person have taken a drug that has been abused, usually the kidney is the one that clears. Pero can you imagine yung mga abused drugs na ito can retain sa body for almost 48 to 72 hours before the kidney and able to clear the body. So that's why some of the drug tests are being taken via urine because it will stay in our body for clearance after 3 days. So how the body will react specifically with the kidney pertaining to the perspective of the elimination. It is through the what we call glomerulofiltrate rate. Once there's an increased GFR or glomerulofiltrate rate, it will facilitate excretion of urine because this is the one that initiates excretion of urine. So this what happens when the drug enters the body. We have the cytochrome P450 by the liver. The metabolite now enters the distal tubules of the kidneys and it will facilitate glomerulofiltrate rate until the drug, excess drug, chemical properties or composition will be removed out of the body via urine. So that's why the major excretion routes of the drugs are the following: kidneys through urine, liver via bile, so that's why it appears in the feces, yung discoloration. Lungs also can facilitate through exhaled air rather. So that's why when a person is in high level of alcohol, you can smell it by the breath eh. Tapos skin also or rather sweat could be a minor excretion routes. Kaya madali ninyong malalaman or you can easily identify a person who's drunk with alcohol, who has high level of alcohol in the body because it manifests to some excretion routes. So via the air as exhaled air, through the sweat, and definitely through the urine. So breast milk could be also one major excretion routes. That's why we need to be careful and we need to be cautious of those individuals or breastfeeding mothers who are taking the drugs because it may pass through breast milk. Other minor excretion routes could be saliva and tears. Now, let us continue the concepts of the nursing pharmacology with the factors that determine proper dosing schedule. Okay, so we have discussed already the route of administration. So it was identified in the absorption because it starts the entry of drug through the route of administration. So, di ba, we have discussed, if you can still remember, parenteral and the enteral routes. So, this is considered as the area of the body where drug is being absorbed. So, that's why, if you can still remember also, yung effect of administration site with the time and effect. So that's why 'di ba yung almost 2 to 3 seconds are the drug reach its peak concentration level pag it is intravenous or intraosseous. Ang pinakamatagal ay yung topical. So it is by skin that lasts through 30 minutes to almost hours pa. So if you say bioavailability, this refers to the drug that reaches peak concentration level and 100%. The other way around is later on is the half-life of the drug. Yung half-life of the drug is when the drug reaches its 50% decrease concentration of the drug. Kaya class, it is very important for us nurses to administer the drug on the right frequency and basically, not other than the right frequency, the proper prescribed time or the prescribed time per se, because this will affect yung bioavailability and the half-life. So again, bioavailability is 100% that it attains its concentration level. Pagka 50%, it is the percentage wherein it decreases already the concentration to half or 50%. So yung onset of action, the onset of action now is different from the duration of action. Okay? The onset of action from the term itself, onset. The onset is a term that is being used, begin. Okay? Begin, start. So pag duration of action, it is the entire. So that is the basic term that you can use to differentiate onset of action and duration of action. Kaya pag sinabi nating onset of action, when the drug already starting, the drug time interval wherein the drug is administered until it starts its therapeutic effect. Yung therapeutic effect is yung purpose, yung desired effect. So on the other hand, we have the peak concentration level. So, di ba, ito yung tinatawag nating Cmax. So, when the drug enters the body, yung peak concentration level ay faster if it will already reach the plasma. So, just like when the drug is being given orally, matagal pa yung mag-peak concentration level because it will pass through the different parts of the body, specifically the GUT or the gut. Unlike for the intravenous drug or intravenous administration rather, it will reach already the blood, and once it reaches the plasma, doon mas mabilis yung peak concentration level. So that means that when the drug reaches the site of action and provided the therapeutic response. This is the one that I am telling you. Yung difference between onset of action at saka yung duration of action. Yung duration of action is yung length of time that produces already the therapeutic effect. Yung kanina, yung onset of action is the start of the therapeutic effect. Yung duration of action is yung entire effect of the drug already. So yung entire, yung length of time is the duration of action. When we talk about the start, the beginning, the initial therapeutic effect of the drug, it's the onset of action. Now, this is what I am referring to, yung bioavailability and drug half-life. So obviously, if the drug attain its peak concentration level, it's 100%, it's bioavailability, and when the drug decreases 50%, it's the drug's half-life. Next, let us now proceed with the self-assessment exercise. And after the self-assessment exercise, we will have our health break. So let's start. The nurse administered the drug intravenously, which is expected 100% absorption. So please put your answers in the chat box. Is it referring to bioavailability? Is it half-life? Is it referring to duration of action? Or is it referring to onset? The nurse administers the drug intravenously, which is expected 100% absorption. A, bioavailability. B, half-life. C, duration of action, or letter D, onset. So we're now receiving 14, 16 responses out of the 28 students on board. So we have 17 responses. So upon checking of responses, so we have now 20 responses, 21 responses. So we are just awaiting for the others. So while 22, thank you so much for the students who are responding well. So hoping we could reach the maximum up to the 28. So 23, good. So most of your answers, it seems all of you have same answers. And one letter that I am now seeing in the chat box. So since we have geared towards 100 absorption and it reached the peak concentration level, then this is the what we call bioavailability. The half-life is the 50% of the drug that decreases concentration. Duration of action, it's referring to the length of time. Yeah, length of time of the entire therapeutic effect. While the onset is the interval by which we are considering the where therapeutic effect begins. So next question. Next question is the nurse administers the drug. So obviously, it is connected to the first question. On the right time and frequency, since the drug plasma concentration reaches 50%. So with that 50%, is it half-life? Is it bioavailability? Is it duration of action? Or is it onset? Again, the nurse administered the drug on the right time and frequency. Since the drug plasma concentration reaches 50%, so very obvious, just be consistent of what is in the question, and you can now get the correct answer among the choices. So we have 20 responses, 21 responses, hoping it could increase into the 28, hoping to have it on 28 responses as a perfect number of participation. So I'll just check your responses, huh? So responses are okay. It seems everyone have the same answer, and it seems you are right. The answer is definitely half-life of the drug. Next question. Next question is, the nurse is aware that a manifestation has been observed at the maximum blood concentration level, the Cmax. Okay? So is it referring to onset? Is it referring to peak concentration level? Is it route of administration? And letter D, half-life. The nurse is aware that the manifestation has been observed at the maximum blood concentration level. So we have already 19 responses, 21 responses. So hoping to increase more, 22. I think that the highest number that we are now gearing at is 23. Ayan, 23. Thank you so much. So hoping it will increase to 24 and up. So, but anyway, I'll just check the answers if majority of you got the correct answer. Okay, so it seems everyone got the correct answers. The answer is the peak concentration level. So that's why when we talk about the peak, we are referring to the maximum. So the onset is the beginning, the route of administration is the area of administration or site, and the half-life is the 50% decrease in the concentration level. Next question. The nurse considered the time interval when drug is administered until the therapeutic effect begins. Now, is it referring to bioavailability, peak concentration level, onset of action, or first pass effect? So the nurse considers the time interval when drug is administered until therapeutic effect begins. So 16, 17, and 18 responses, 19. Just continue. So for those who are traveling, be safe, ha? So for those who are still in school, be in the conducive learning space po or learning environment. So we have 21 responses. Can I still expect 23? So let's see. So we still have 21 responses and pending on the 21. So 22, hoping to reach 23. So I'll just check your responses. So it seems, again, very consistent. All of you got the correct answer. So we have the onset of action because of the term that we have considered as the therapeutic effect begins. Next, we have yan. Okay. So I think before we continue, it's almost 6:06. We may have 15 minutes health break for you to hydrate yourselves, stretch your extremities for circulation. So we will be back after 15 to 20 minutes. Thank you so much. So let us continue with our discussion. So let's go back. And I hope everyone have hydrated themselves and stretched their extremities. So let's continue. Patient safety is very important, significantly on the discharge of roles of nurses. And one of the core priority is on the administration of medication. So I even mentioned that most of the medical administration errors committed the error rate of 60% and almost 34 mainly in the form of a problem with the wrong time, with the wrong rate, and the wrong dose. So that's why these are the common medication checklist that you may have. Other than later on, we'll have a discussion related to the other rights of medication. The proper time given because we have mentioned that this is very important in terms of the bioavailability or the principles of bioavailability and the half-life. The right route because class drugs have different preparations and this preparations is intended for the specific route. So we have been aware of the drug preparation itself, the time, and its effect. The right amount or dose will identify basically on the underdosage or the overdosage. So dosage is very significant, and with the initial data that you may have or that you may need when it comes to the administration of drug and in the composition of the dose is D over S times Q, which means dose over stock times quantity. So weight is also very important when it comes to the computation or calculation of the drug dose. Medication, the right medication. So it's very important to identify generic names and brand names. But moreover, you need to uh, be familiar with generic names because this will guide you on the functional classification. On the right patient, all you need to do is to identify or to consider two identifiers. It's either ask the patient's name or number two to check the ID band of the client. So this trump could be translated here as a way of how you will promote safety. Thus, we have also the 12 rights of medication. So the dear patient thread. D is the right documentation, E, evaluation, A, assessment. R, right reason. Right patient, right time. Red, right route and refuse. Right E, expiration date and education. And D, the right drug and the right dose. So it is very important to consider po for the right documentation that everything that you will assess to your patient at the time that the patient received the drug, and if the patient experiences adverse reactions, this must be all documented. And if ever there are some situations that you did not administer the drug, your colleague administered the drug, you must not be the one to affix your signature in the medication sheet. So you must be consistent on this perspective because there is a legal imperative on those actions. Right evaluation is very important. Don't be afraid of if ever there are situations that adverse reaction had been identified because it's a matter of being an effective nurse because you have been alarmed with adverse reactions and that evaluation findings will lead the patient not to risk with any complication. Third, right assessment. Vital signs are very significant so that you will have a basis to pursue the administration of the drug or withhold the drug. Fourth, right reason. Right reason, it may depend yung client when it comes to the explanation of why the drug has been taken, why the drug had been ordered by the doctor, and why the drug had been prescribed for his treatment. Right patient, we have identified two identifiers. Right time and frequency is significant for bioavailability and the half-life. 7, right to refuse. For the right to refuse, um, if there's an institutional policy that the client refuse the drug, so you must refer it into a waiver. Then Moreover, if the patient refuse, it is still in the responsibility of the nurse to convince the client because eventually the drug had been prescribed because of the treatment regimen. But if the client only complained that he or she doesn't want the taste, he or she doesn't want or she experiences discomfort as side effects. So these are the things that can be managed by nurses. And eventually, let's go back to the reason why the patient is receiving such drugs. The right route, right expiration date. Okay, let's put this in the right perspective ha. Expiration date are being reflected in drugs. And there's no concept that it can still be taken after a week, after a month, after 3 months. Class. There could be two effects of expired drug that you may take. It could be primarily, it will cause toxic effect to your body, or you can take it, but nothing happens. It means the drug is useless. These are the two concerns that a patient may have the expired date, expired drug rather. The right education is very important to make the patient or to consider the patient's independence. For the patient to report immediately adverse reactions and to report any discomfort that is brought about by the side effect. So yung difference again natin with the side effect, we've considered that this is the expected physiologic, but the adverse reactions are those that are harmful reactions of drug. So we have the right drug and the right dose. So eventually, actually this is the last slide. Ah, this will be the last slide. Okay. But I think this will help you on how to consider po common medication suffixes. So, alam niyo po class, when you encounter or when you have heard about pharmacology, I know that you have this anxiety that you will memorize all of those drugs. So this could be an initial tip for you to be guided. Consider only generic names because the brand names are the ones being labeled accordingly by pharmaceutical companies for the drug to be identified in a certain manufacturing or pharmaceutical companies. But the suffixes itself may conclude yung classification niya as per the generic. So let's start with cane. I know probably you may ask, cocaine. Okay? So, sir, sabi ng ang cane ay mga local anesthetics or anesthetics. Lidocaine, bupivacaine, lontocaine, cocaine. Di ba class, remember, cocaine had been a discussion in the medical debates that it could be used na for the medical treatment. But as of now, it is still regulated and it has not been accepted for now to use this as anesthetics. Sir, what is the difference between analgesic and anesthetic? Okay? Ang analgesic, obviously, it blocks the pain receptor that cause the motor response pain. Ang anesthesia, it will cause loss of sensation. So loss of sensation for pain. Talagang totally loss of sensation. Either you will have your loss of consciousness or not. So that's the difference. So iba naman yung local anesthetic. Pag sinabi nating local anesthetic, from the term itself, local, it has the certain area only that will cause anesthetic effect. Example, if the client if the client will be subject for a certain operation, then it will cause only anesthetic effect or loss of sensation on the specific area. For example, if there will be a removal of mass in the breast, so it will not cause anesthetic effect to other parts of the body. From the time that you have received or you have administered the local anesthesia, it's within the area lang magkakos ng anesthetic effect. So, ang kailangan lang nating i-consider po class, ang local anesthetics are being given, yung mga lidocaine lidocaine are being given intramuscularly. But for the rest, yung mga ibang mga anesthesia could be given spinal. So pag spinal anesthesia, ang spinal anesthesia, ang anesthetic effect niyan, abdominal area down. Okay? Yun yung effect niyan. Kaya pag nagpa-pain pag nagpe-pain painless delivery, usually nagko-cause yan ng loss of sensation from abdominal below. Pero si patient pa rin, conscious pa rin, so that if there is a situation that there is uterine contraction, the patient can still have the consciousness to bear down pag sa mga normal delivery. So pagka the general anesthesia will cause anesthetic effects or loss of pain sensation for the whole body. So let's proceed to next. Done. Okay, done. So we have hydrocodone, oxycodone, methadone. Kahit anong done ang huli, done, opioid analgesic siya. So we have discussed analgesic as a pain reliever. Yun nga lang, anong difference, sir? Ang narcotic at opioid analgesic, pareho lang siya. Ano ang pinagkaiba niya, sir, sa atypical analgesic? Yung narcotic analgesic at opioid analgesic po, kasi direct sa brain pain receptor po ang pag-block ng motor response for pain. Kaya usually, ang mga opioid analgesics nagkakos yan ng drowsiness. So, at ang opioid analgesics po usually must be prescribed by a licensed S2 doctor. S2 is a license by which they are only authorized to prescribe regulated drugs. Kaya yung mga opioid analgesics, narcotic analgesics, careful po ang pag-administer nito. Kasi since direct sa brain po ang pag-block ng pain receptor, pag nag-overdose po dito, pwedeng mag-loss of consciousness at the same time, mag-suppress sa brain. Pag nag-suppress sa brain yan, pwede maapektuhan ng major organs from breathing up to the cardiac rate. So we have cane. These are local anesthetics. Opioid analgesics are those drugs ending in done. Next po, we have mycin. Terramycin, erythromycin, clarithromycin, azithromycin, gentamicin. So as long that the drug ends in mycin, these are antimicrobial. Usually, an example nito, yung mga erythromycin are indicated for tuberculosis or other respiratory infection. Azithromycin, ito very familiar kayo dito. These are the drugs or rather the antibiotic for respiratory infection na ginamit ng COVID-19 na usually ang common dosage nito, it should be taken only for 2 days. But this was used during the time of the COVID-19 infection management. So, mycin. One thing that I will advise you po on this is that you must have taken this in full stomach. Okay? Because this drug will really cause gastric irritation. Lahat ng may mycin, always take this with full stomach. Next, I know if we go back to your microbiology and parasitology, napag-aralan nyo po yung mga gram-negative bacteria and gram-positive bacteria. This could be identified through culture sensitivity tests, right? So this is important to significantly identify the appropriate medication, okay? The appropriate medication intended for a certain diagnosis or infection. Now, if there is no test that has been done, such as the culture and sensitivity test to identify the specific microorganism, so that to combat both gram-negative and gram-positive, there is a broad spectrum antibiotics. Okay. So ano yung mga situations na talagang very severe na yung infection? Sepsis is a severe infection, ha? This is the medical term for severe infection. Other than that, yung mga wound infection na may pus or may discharge na, ito yung mga gamot na really considered for prescription. Why? Kasi ito yung mga ito yung mga mga infections na pwedeng mag-travel na yan through the circulation at mag-reach into the different organs of the body. That's why broad spectrum antibiotics are being used. So that's why ginamit din to sa COVID-19 eh. Etong mga broad spectrum antibiotics, yung mga oxacin, levofloxacin, ciprofloxacin, norfloxacin, lahat ng oxacins, Okay? Oxacin are broad-spectrum antibiotics. Another familiar drug, drugs ending in beer. Yung may mga abacavir, aciclovir, adefovir, monoclovir. So ginamit yan sa COVID-19. Lahat ng may vir sa huli, these are antivirals. Okay? Actually, isa dito sa drug that I mentioned, it was used not to worsen yung mga chickenpox. So, aciclovir, it's one that is being used because chickenpox is caused by a virus. Okay? Next po, DIN or DINE. Okay. I will explain this in a way. Number one, I know all of you or everyone here experiences hyperacidity. Some are controlled, some are not. So if you experience hyperacidity, the drug that will counteract hyperacidity is alkaline, 'di ba, sa acid and base. So base component drug. So sisimulan natin sa antacids. Okay, kaya nga pangontra, antacids. These are drugs that has sa mga generic niya, magnesium, aluminum, yan yung mga common. Okay? So, kinokontra niya yung acid level kasi yung base yung magnesium and aluminum. Yun lang, be very careful. Pag ang patient ninyo is experiencing hyperacidity tapos nagdadiarrhea, don't give magnesium kasi ang side effect ng magnesium sa generic ay nagkokos lalo ng diarrhea. So pwede ma-dehydrate yung patient. So on the other hand, if your patient is having hyperacidity at nagdadiarrhea, ang ibigay ninyo yung aluminum hydroxide na, yung may aluminum. Ngayon, if the patient naman is experiencing constipation, don't give aluminum kasi yung aluminum ang side effect niya constipation. So mag-aggravate yung constipation. So on the other hand, ang ibibigay the one that you will give is the drug that has component of magnesium. So that's clear ha. So I even experienced this at the time that I have the cholelithiasis or stone in the gallbladder. The pain is very severe. Talagang it may not be managed by antacids. Then the next drug that was prescribed during the time that I experienced hyperacidity caused by the gallbladder stone, we have yung ano po, may situations wherein that hindi pag it will not be tolerated by antacids, an anti-ulcer agent such as histamine 2 blockers are given. Remember class, meron tayong histamine 1, meron tayong histamine 2. Okay? Ang histamine 2, ito po yung what you call this, impulse transmitter or neurotransmitter na nagtatransmit ng signal sa epithelial cells ng stomach para mag-produce ng hydrochloric acid. So ibig sabihin, pag histamine 2 blocker, pag binlock mo yung histamine 2, hindi magta-transmit ng impulse yan to stimulate hydrochloric acid production. So kinokontrol niya yung pag-produce ng hydrochloric acid. So ito yung mga ranitidine, famotidine, cimetidine. Ngayon, this H2 blocker or histamine 2 blockers, anyway, pag tinanong nyo, sir, saan ba yung histamine 1? Yung histamine 1 naman, ito po ay present naman sa bronchi. Kaya pag mga ina-asthma, yung histamine 1 is the one that constricts the bronchi. Histamine 1 yon. Kaya nagbibigay, di ba, mga antihistamine. Yan. So, iba naman tong histamine 2 blocker. Ang histamine 2 naman ay present sa stomach. So, ito yung mga tidine. But in my situation, such as cholelithiasis, it has no effect. Ang hirap. So the next drug po that was prescribed ay yung may mga prazole sa huli. Omeprazole, lansoprazole, pantoprazole, esomeprazole. So ito po na yung talagang drug that will focus na on the cellular function para ma-prevent yung hydrochloric acid production. Ang tawag naman po sa mga prazole, ang end ay proton pump inhibitor. So yung ini-inhibit doon ay mismong sa cell na to prevent yung pag-pump, pag-produce ng hydrochloric acid. So before I proceed, I saw a question. Question lang po, lahat po ba ng antibiotics are taken after meal? Last time po kasi, niresetahan ako ng doktor ko na mag-take ng antibiotic always before meal. That need maghintay na 1 hour bago po kumain. Dahil po doon, sobrang nahihilo po ako after inumin yung gamot at pakiramdam ko na lahat ng kinain ko the whole day na wala. Ganito po yon. May mga antibiotics that are being given on an empty stomach. These are the drugs such as rifampicin. Ito yung tinitake before meal para yung drug will have its efficient and effective absorption. Yung talagang ita-target niya agad yung concentration of the drug. Kasi imagine niyo, di ba? Pag ang drug ay minix mo sa food, can you imagine yung nagda-digest doon, nada-digest yung drug mo, binibreak yung drug mo, binibreak din yung food. So maraming process are being done. Unlike for the drug that is on an empty stomach, it will break down the drug and concentration itself is high. Unlike for the drug that is mixed with food. However, the purpose lang natin is why drug is being with the food because most of the antibiotics are gastric irritant. So yun po. So sometimes or there are some situations your doctors will prescribe antibiotic 1 hour before meal. It's because para po yung absorption of the drug mataas yung concentration at maging effective. That's the purpose. Yun nga lang, if you may experience discomfort on these drugs if taken before meal, please don't be hesitant to inform your doctor kasi this may cause the possibility naman na nai-irritate na yung gastric mucosa at pwedeng maging ulcer. So the doctor will have a different i-hold na, i-change na yung drug mo if you are experiencing discomfort on a certain type of antibiotic. Next po, drugs ending in lam and drugs ending in pam. So these are the drugs such as yung mga lorazepam, diazepam, clonazepam, midazolam. So ito po yung mga drugs wherein it considered po yung pampakalma. Kaya sasabihin nito, kaya pag may pumunta sa mga emergency room, naghi-hysterical siya. Pag please administer diazepam. So pampakalma siya. Anti-anxiety agents po ito. Pero ang diazepam again Valium ito by brand name. These are drugs na regulated po yan. Hindi po yan nabibili agad-agad in the pharmacy. So this must be prescribed again by a licensed S2 doctor. Okay, clear? So next po, we have NIUM, N-I-U-M. Pag NIUM naman, neuromuscular blockers. If you're familiar with Parkinson's disease, ito yung nagkukos ng mga tremors. Pag sinabi natin tremors, these are involuntary muscle movement. Those muscle contractions that cannot be controlled, kaya nagkukos yan ng involuntary movements. So to control this, meron tayong tinatawag na neuromuscular blockers at these drugs are ending in NIUM. So pancuronium, becuronium, rocuronium, so NIUM, neuromuscular blockers. Next, ask your parents, those who are taking antihypertensive, at for those who may have high level of cholesterol, this is the drug that are being prescribed. Statin. Those drugs ending in statin are anti-hyperlipidemics or anti-hypercholesterolemia. So, simvastatin, rosuvastatin, fluvastatin. So, as long any drug na lumabas in the market that ends in statin, always consider this as anti-hypercholesterolemia. So, ibig sabihin, if you notice, nagko-concentrate lang tayo dun sa suffixes kahit hindi nyo na i-memorize yung mga sample drugs. Kasi the suffixes itself will guide you on the specific classification of drug. Okay? Ang statins po, dahil sa cholesterol siya, these are drugs being given sa patient natin once a day at night. The question, sir, why at night? Because at night po, yan po yung peak po na ang cholesterol po ay hindi nasisynthesize ng liver at ng body. At dyan po yung peak na pwedeng mag-cause po ng obstruction of blood vessels and may lead to heart attack. Next, drugs ending in IDE. IDE. So ano naman po yung IDE? Oral hypoglycemics. If we say hypoglycemics, hypo, mababa, glycy, sugar, emia, blood. So these are the drugs that are usually maintenance po ito ng mga patients who are diabetic and with uncontrolled sugar level. So ito yung mga glimepiride, glipizide, gluperide, lahat ng may ide ha, except tide, sabon. Okay. So doon, ang lahat ng ide ay oral hypoglycemics. Again, the next suffix that we will discuss is zone. Zone are steroids. Okay. Probably you will ask, sir, ang steroids po ba ay binibigay po intramuscularly? By drug literature, hindi. Kaya what you have heard about if dexamethasone are being given para daw sa mga gustong maging able-bodied. Pero it is not in the drug literature that it must be given intramuscularly. So these individuals are taking the risk. If you will be asked to give steroids intramuscularly, think twice, because that is not indicated in the drug literature. Unless you will see in the packaging, in the ampule or in the vial, that is for intramuscular. But if it's not for intramuscular route, then don't think twice. Think twice rather. Think twice, and not to take risk of administering the drug. So, ang mga zone po, ito po yung mga dexamethasone, hydrocortisone, betamethasone, prednisone. Alam nyo po, ito po ay isa rin sa mga drug na nagkukos ng gastric irritation at pwedeng mag-proceed sa gastric bleeding. Ito po yung drug, yung mga zone na ito, ay wag na wag nyong iti-take ng empty stomach. Talagang it will give you the severe and worse gastric pain. Okay? At ang mga steroids po na oral ay hindi po yan mini-maintenance kasi it will cause damage sa kidneys. Unless may mga chronic illnesses po, specifically yung may mga itis yung huli, 'di ba? Yung mga pleuritis, pericarditis, cellulitis. So these are inflammatory diseases which steroids are being given. Okay, next. Punta na po tayo sa next classification or suffix, ZIDE and MIDE. Okay. Sa ZIDE and MIDE, ito po yung diuretics. Pag nakakarinig po kayo ng diuretics, ito yung usually na within 24 hours, nakikita mo na yung increase in weight. Tapos, you will observe sa foot niya ay minamanas. Manas is different from maga because the manas is brought about by accumulation of fluid. May swelling siya but caused by accumulation of fluid. Pero pag there is a swelling that is caused by the inflammation of tissues, yun ang maga. Pero yung manas is different from the maga. It's because it's caused by accumulation of fluid. Pag may accumulation of fluid sa foot, yan, edema ang tawag doon, pitting edema. Primarily check your kidneys. Okay? Now, ibig sabihin yung retention of fluid, dapat nilalabas yun ng kidney eh. And it must not manifest with those. Pag may mga cardiomegaly, yan yung mga enlarged heart, lungs with fluids, yan common po pinibigay ang mga diuretics. Ang concern nyo lang dito dahil nga nag-i-induce ito ng pag-ihi, individuals could be high risk of dehydration, specifically affecting potassium. Kaya pag nagda-diuretics po, as much as possible, i-check po ang potassium level. Next, last three. We have Pril. Pera ang April ha. Okay? But malay natin pag nagkagamot ng April, sabi mo sir, those drugs that all end in Pril. O, ngayon, ay ACE inhibitor. Ang tinatawag nating ACE inhibitor, pag sinabi po nating ACE, these are anti-hypertensive drug. Ito po yung drug by which high blood yung person, tapos yung kidney tumutulong to regulate blood pressure. Pero situation goes na dahil sa adrenaline na nire-release ng kidneys natin to help regulate the blood pressure, meron pala siyang effect pabalik sa kidney. So that's why pagka ang person po, eto ha, pag ang person po ay meron ng problem sa blood pressure tapos medyo may affected ng kidney, ang binibigay po ay mga ACE inhibitor. At those drugs ending in pril, captopril, isinopril or enalapril. Class, ito yung drug na anti-hypertensive pero binibigay siya ng 1 hour before meal. Because again, to promote effective absorption. Next, last two. For the last two drug, we have PIN. Actually, dipin to eh. Dipin and amil. Yung amil, isa lang yan, verapamil. Pero most dipin. Yung pelodipin, amlodipin, nifedipine. Okay. Class, calcium channel blockers. Why it is called as calcium channel blockers? Alam niyo po class, for those who have already cardiovascular diseases, ang nangyayari po dyan is, for example, nag-cause ng constriction yung blood vessel caused by the smoke, caused by the alcohol. Alam nyo po nai-irritate yung mga blood vessels, lalo na yung mga coronary blood vessels of the heart. Mabilis po yan mag-cause ng inflammation at damage. Ngayon, pag namaga po ang blood vessels, hindi na po yan magko-contract. Hindi yan magpo-push ng blood. And what will happen? Hindi siya magsusupply ng oxygen to the cardiac muscle cells. So ang patient mo magche-chest pain. Ang problema, ang normal response ng body pag may problem sa blood vessels, si calcium tutulong. To the rescue, calcium. Kaso pag severe yung damage sa blood vessels, si calcium continuously yan nagre-release to compensate mag-contract ng blood vessels. Kaso pag sumobra naman yung calcium, magde-decalcify. Ano ibig sabihin ng magde-decalcify? Mag-hardening. Yan naman yung problem pag mag-hardening. Iniiwasan nga, ini-induce nga po natin para mag-contract, tapos si calcium naman magkukos ng hardening. So para ma-prevent yung problem na yon, yung medical term dyan, sclerosis, is that of magbibigay tayo ng mga calcium channel blockers. Okay, last drug sa PICS, olol. For the olol, ito yung pangit pakinggan, no? Pero madaling tandaan. Kasi yung olol, metropolol, atenolol, propranolol. Have you known a person who has goiter or hyperthyroidism? Pag hyperthyroidism, increase yung thyroid hormone. Pag increase yung hormone, increase yung metabolic activity. So pag increase yung metabolic activity, yung body mo, parang hyper lahat yan. Yung kidneys mo, yung adrenaline mo. So what happens? Ang heart mo, parating nakaka-receive yan ng adrenaline. So forceful. So kung forceful po ang pag-contract ng heart, mapipil mo yon. Anong tawag doon? Type it in the chat box. Even though you will not auscultate, but you will feel that your heart is forcefully contracting. It starts with letter P. What is that medical term? Okay, we have already one response. The answer is correct, Miss Anos, palpitation. Palpitation is an indication that the heart is forcefully contracting at nag-i-increase ang oxygen demand. To manage po yung ma-regulate yung contraction ng heart, in spite of those situation, magbibigay po tayo ng beta blocker. O kanina sir, meron kang histamine, ngayon naman beta. Yung beta po, yung beta receptor. Yung beta receptor is the one that gives signal sa heart. Kung kailangan niya, for example, nag-release ng adrenaline, si beta receptor po ang magbibigay ng signal to the heart so that it will stimulate to contract. Pag binlock mo siya, di syempre, babagal yung contraction kasi binablock mo yung signal. So these are the drugs that are very common or the suffixes. I hope you have learned those suffixes, and eventually we will continue to have more drugs to discuss using these suffixes po. So I think this is my last slide for our synchronous session, and I will end up my